Mechanical ventilation basics. By the end of this lecture, you should be able to describe the physical principles governing mechanical ventilation, explain the main determinants of oxygenation and carbon dioxide removal, predict the complications that occur to a patient on mechanical ventilation. At this point, I want you to think for a minute. If you were designing a machine to move gas in and out of the lungs, what properties of the lungs would influence your design? Hopefully, you came up with the resistance and compliance of the respiratory system. In simple terms, the lung ventilator unit can be thought of as a tube with a balloon on the end, with the tube representing the ventilator tubing, endotracheal tube and airways, and the balloon the alveoli. Gas is pumped into the lung during inspiration and flows out passively during expiration. In order to produce a flow of gas, there needs to be a pressure difference between the outside and the inside. What determines the pressure required to produce flow of gas along a tube? The pressure required to make gas flow down a tube is determined by the resistance and the flow rate. What determines the pressure required to inflate a balloon? The pressure required is determined by the volume to which the balloon is distended and the compliance of the balloon. Thus, the pressure required to inflate the lung is the pressure required to push gas down the tube plus the pressure required to inflate the balloon. That is, the sum of flow times resistance plus volume divided by compliance. However, the pressure measured at point A, or the airway pressure, will not simply be the inflation pressure, but will also include the baseline pressure in the balloon. This baseline pressure is the pressure in the balloon at the end of expiration, which is known as the positive end expiratory pressure, or PEEP. Thus, airway pressure is equal to flow times resistance plus volume divided by compliance plus PEEP. The component due to alveolar pressure is equal to volume divided by compliance plus PEEP. Look at the equation. Is it possible to set pressure, flow, and volume independently? As pressure, flow, and volume are all related, it's only possible to set any two of these three variables, with the third being dependent on the settings for the other two. However, flow is equal to volume divided by time, so if time is set, it's only possible to set one of pressure, volume, or flow. The function of the ventilator is to help get oxygen into the patient and carbon dioxide out. The most important means of improving oxygenation are to increase the inspired concentration of oxygen and reduce shunting by increasing PEEP or prolonging inspiratory time. Carbon dioxide removal can be increased by increasing the respiratory rate or tidal volume. PEEP works to decrease shunting by reopening alveoli and keeping them open. Inspiratory time can be set as a percentage of the respiratory cycle or as a ratio of inspiration to expiration, the so-called IE ratio. Alternatively, it may be set as an absolute or fixed time or indirectly by setting flow. Note that on most ventilators, the expiratory time is not set directly, but is merely the remaining time after inspiration before the next breath. Although increasing the inspiratory time may improve oxygenation, inspiratory times of more than 30% or IE ratios of more than 1 to 2 are often uncomfortable for the patient, resulting in a need for a deeper level of sedation. In addition, less time is available for expiration, resulting in an increased risk of gas trapping. Now that's quite a lot to take in, so we'll pause here for a minute while you think of and write down two important messages you've learned so far. Respiratory complications of mechanical ventilation include nosocomial pneumonia, ventilator-associated lung injury, and gas trap. Ventilator-associated lung injury may result from high pressures, volume, or shear injury. The term barotrauma is best reserved for those gas leak syndromes, which are due at least in part to excessive inflation pressures, namely pneumothorax, pneumomediastinum, pneumopericardium, pneumoperitoneum, and pulmonary interstitial emphysema. Volutrauma refers to the development of an acute lung injury, histologically similar to ARDS, when lungs are repeatedly distended to excessive volumes. Shear injury is the result of repetitive collapse and re-expansion of alveoli, and is due to tension at the interface between open and closed alveoli. Gas trapping may occur if there is insufficient time for alveoli to empty before the next breath. It is more likely to occur in patients with asthma or COPD, when inspiratory time is long and therefore expiratory time is short, or when the respiratory rate is high and therefore the absolute expiratory time short. Large tidal volumes similarly increase the probability that the expiration will be incomplete when inspiration begins again. Gas trapping results in progressive hyperinflation of alveoli and a progressive rise in end expiratory pressure. As this increase in PEEP is not due to an increase in set PEEP, it is known as intrinsic PEEP. By measuring total PEEP, it's possible to measure the degree of gas trapping. Intrinsic PEEP is variably defined as total PEEP, or as the difference between total PEEP and extrinsic PEEP. It's probably simpler to refer to total PEEP, which can be measured on most ventilators by using the expiratory pause hold control. As the pressures in the respiratory system equilibrate, the expiratory pressure measured by the ventilator rises. This occurs after a few seconds. The pressure displayed is the total PEEP. Adverse effects include barotrauma and cardiovascular compromise due to high intrathoracic pressure. In an extreme case, this can lead to cardiac arrest with pulseless electrical activity. Positive pressure ventilation reduces the preload. This is predominantly due to reduced venous return. Normally, venous return is enhanced by the negative intrathoracic pressure during inspiration. Not only is this abolished by positive pressure ventilation, but venous return is actually impeded by the positive intrathoracic pressures. This effect will be exacerbated by any factors that increase the mean intrathoracic pressure, such as high inspiratory pressures, prolonged inspiratory times, and the application of PEEP. Left ventricular afterload is the tension in the left ventricular wall during systole. It is dependent on the transmural pressure, the radius of the ventricle, and the thickness of the wall. Transmural pressure is the pressure inside the ventricle, the intracavity pressure, minus the pressure outside the ventricle, the pleural pressure. As mechanical ventilation increases pleural pressure, it will reduce transmural pressure and ventricular wall tension, and hence afterload. Decreasing preload and decreasing afterload have opposite effects on cardiac output. The overall effect depends on whether ventricular contractility is normal or abnormal. If the patient has decreased contractility, as is common in critically ill patients, cardiac output is increased by mechanical ventilation. If the ventricle has normal contractility, then cardiac output tends to fall with positive pressure ventilation. If the patient becomes hypotensive shortly after intubation and ventilation, the most likely causes are drug-induced hypotension due to the vasodilating properties of anesthetic induction agents, gas trapping due to overenthusiastic ventilation, and tension pneumothorax. Drug-induced hypotension usually responds to fluid load. If gas trapping is suspected, disconnect the patient from the ventilator. As the trapped gas is released, the hypotension will resolve, usually within 30 to 60 seconds. A tension pneumothorax is rare, but the possibility should be considered as it is easily treated and failure to diagnose it may be fatal. Treatment is by needle thoracostomy. Okay, before our final summary, I'd like to write down 3 things you learned from this lecture that you think are important messages. Perhaps things you would tell a colleague who missed the lecture. In summary, the airway pressure is determined by the flow times resistance plus volume divided by compliance plus PEEP. Oxygen transfer into the blood is increased by increasing the inspired oxygen concentration, the PEEP, and the inspiratory time. Removal of carbon dioxide is determined by the alveolar minute ventilation, which is dependent on the respiratory rate and the tidal volume. Important complications of ventilation include hypotension, ventilator-associated lung injury, and gas trapping.